Good.
Okay, it's 2 minutes past 5. The numbers of participants are no longer quickly going up, so I think it's time to start. And I'd like to welcome you after the summer break we had with all the webinars. I'd like to welcome you back to the webinar of the spine section, which we had the last one, I think, in June, and we're now continuing during the autumn and winter with the upcoming webinars. Today we have as a guest, as a speaker, Massimo Balzano from Italy. Massimo Balzano is an orthopedic surgeon who was originally trained went to med school and was trained as orthopedic surgeon in Padua, Italy, and then had some different positions. And now he's holding the position as chairman of the spine department at the University of Verona in Italy. He's a very well-known expert especially in treating spinal deformities with open surgery, minimal invasive surgery, doing all different accesses to the thoracolumbar spine. And apart from that, he's also very experienced in all other disciplines of spine surgery. He's a very good friend to the EANS, giving valuable contributions to courses, training courses, as well as the advanced courses since many years. And he's always giving very excellent presentations. And I'm really happy to have you here tonight, Massimo, to give this presentation. The title of the presentation is I think it's a difficult topic, as it's on adult deformities, which are or can end up in very long construct, very long spinal stabilizations and fusions. And it's always hard to find the adequate decision for the individual patient on where to start and where to stop, and how long these constructs need to be, and whether a construct or a stabilization is necessary. And I'm happy, Massimo, to hear from you how we should treat adult spinal deformities, when, why, and how. That's how we named the presentation. Thanks, Massimo.
Thank you so much, Florian. Thank you for the invitation. EANS is my house, because also I'm not a neurosurgeon, but I'm very close to neurosurgeons environment, and I'm very happy to be invited to speak to the members, especially to the young people. And now today we have to speak about adult scoliosis. You know, is a very, as you said, is a very interesting topic, and very tough to decide when to operate or not. And this is very important for young generation to understand how is this kind of surgery and how to approach to it. So now I start to share my screen, and I hope you can see it. Everybody can see. And I go over. And as Florian said, I'm the director of a spinal regional department at the University and Hospital Trust in Verona, Italy. And these are my disclosure. Actually, I'm also the president of the International Society for Advanced Spinal Surgery. And now, that's the definition of adult scoliosis. It's a lateral curvature of a spine of more than 10 degrees in a skeletal mature patients. And very simple, we can divide in two types: de novo, that starts from a normal spine, or coming from adult idiopathic scoliosis. For your information, so can be considered as de novo, as I told you before, but means starting from a normal spine or as evolution of pre-existing idiopathic deformity. So what we see in adult degenerative scoliosis, we see a lot of anatomical problems. So we can have a clinically and neurological deficits, maybe radiculopathy, claudication, that are the main issues. And the patients come to our clinics for this. But also they are more painful, usually are more painful by low back pain, but also low back pain is very, very important to assess. And in this case, the pain is usually typically mechanic. And we have assisted to a vertebral orthostasis with a retroflexis, yellow ligaments, and hypertrophy, you can see here in this specimen, and hypertrophy of the facet joints, enlargement of the disc, and these are responsible for the collapse and the compression of the caudal. And this is, you see here, how is the anatomical problems that we can, the pathological problem that we have in these deformities, and can be very mild and sometimes are very aggressive. In 2005, Max Sebi is a very famous orthopedic spine surgeon, has classified adult scoliosis in mainly in 4 types. As you see here, type 1 comes from primary degenerative scoliosis, as I told you before, de novo scoliosis, and the etiology is an asymmetric disc degeneration and facet joint degeneration. And type 2, progressive idiopathic scoliosis of the lumbar and thoracolumbar spine, and this etiology comes from an idiopathic scoliosis that was present in the adolescent age. And type 3A, adult scoliosis are secondary to adjacent thoracic thoracolumbar curve or of idiopathic or neuromuscular or congenital origin, maybe obliquity of the pelvis and something like this. And type 3B, deformity progression mostly to bone weakness, maybe osteoporotic or fracture with secondary deformity. But later, another type of classification was studied and was performed by the group of the Scoliosis Research Society, Frank Schwab's, and now here we can assist to have the different types, that means the type T, the type L or TL, so only thoracic, or lumbar only, or double curve, or when we have to consider now the sagittal deformity. That is very important. And the sagittal deformity leads to 3 modifiers. And modifiers, you know, we have to assess the pelvic index. So when pelvic incidence is minus the lumbar lordosis, we have A, B, and C. You see within 10 degrees, B between 10 and 20, and C more than 20 degrees. And, oh, sorry. When we have the pelvic tilt to consider, less than 20, between 20 and 30, and more than 30. That is a very aggressive pelvic tilt. And after the global balance, normal when SVA is less than 4 centimeters, sacroventral alignment, and sagittal ventral alignment, and P between 4 and 9.5, and when sacral vertical alignment is more than 10 centimeters, 9.5, is a very aggressive curve. So now, why we have to think of in scoliosis in surgery? There are a lot of papers in literature. This is interesting because was published 3 years ago in JBJS. So operative versus non-operative treatment for adult symptomatic lumbar scoliosis. And this is interesting because they have done a study of people between 14 and 80 years old. And when there was a coronal cob angle more than 30 degrees, ODI more than 20, and score of SRS 22, that is the score assessment usually used for for the assessment of the clinical problems of the patients. And the study in North American, and this was study in North American. And finally, at the end of the story, there was no was difficult to establish when is operated or non-operated best way. But if you look at, you see here, if you look at the diagram of SRS 22 score or the ODI score, we see that the SRS is better when you operate after years, and better, you see here, non-operated and operated. And as well, the ODI score is better when you operate than you non-operate. So the decision making is up to the experience of the team, but now I go up to show you what I mean. Another paper, adult scoliosis, a health assessment analysis by SF36. You know, SF36 is a very health system score, and we know for that SF36 in scoliosis decreases significantly the quality of life in adult population between 55 and 64 years. So for sure, we have a bad life when we have a deformity. And this is another paper for you, a decision published 6 years ago. The title is A Decision Analysis to Identify the Ideal Treatment for Adult Spinal Deformity. Is surgery better than non-surgical treatment in improving health-related quality of life? And this is the study done by European Spine Study Group. And finally, also, this study has demonstrated that a real best modality for SD may not exist. So it's up to the experience of a team, to the hospital care, and some other decision makings. But of course, when we have to deal with a patient like this, of course, is completely different from another patient where the deformity is not so aggressive. This is a real aggressive deformity, and the quality of life of this patient, of course, is not good. So for sure, this patient needs a surgery. So indication for surgery are the most important. So we have to know what we are trying to accomplish. First is the pain recovery. Then we have to reduce the use of medications. You know, opioids are very, very used, especially in North America, and of course can have a big problems to the normal quality of life for these patients. And after the indication, if we think to surgery, our goal is to improve the quality of life, of course. So how can we get this? And I like these papers of Larry Lenke, the famous spinal deformity surgeon, that 10 years ago has published this paper, and he has divided the different types of surgery we can do to a patient. So six levels difference of operative treatment, starting from, you see here, only decompression when we have only neurogenic problem and you have not a mechanical problem, and step by step you go from one point to big aggressive surgery like the pedicle subsection osteotomy or BCR, the vertebral column realignment, that are very, very aggressive for surgery. So in a burden of this scheme, you can find your solution. Of course, the complications are low when you are in the first row here, 1.1, and are more representative when you perform osteotomies. You see here in this square, I put this 2.2 with short lumbar fusion of the compressor area of a spine when you have neurogenic complaints, less than 30 degrees a curve when it's stable and balanced. We have to fuse the entire lumbar curve fusion. And this in this square probably are the most indicated for the MIS surgery, minimal invasive surgery, but I speak of this a little bit later. Which are the most important factors related to disability? Usually in the literature are surgical vertical alignment more than 5 centimeters, the mismatch between pelvic index incidence and lumbar lordosis of 10 degrees and pelvic tilt more than 25. This is accepted by literature as the factors related to disability. Let me show you some examples of cases. I have a case of a patient that has this deformity in sagittal. You see, pelvic tilt is very high, 45, and SVA is very high. And we have done this surgery. We have done an asymmetric pedicle subtraction osteotomy in L3, free thoracic SPO, that is Smith-Peterson osteotomy or Ponte osteotomy, and we have rebalanced the spine very well way. And this is the patients before and after surgery. But for this kind of surgery, we have done 3 days of ICU, severe blood loss, 3 liters, 15 days of hospital, long time for recovery, 1 year for returning to full activity, sorry, and increased cost for health system. Of course, she is fine, because if you see here, the quality of his before and after surgery was different. The balance of spine was very good. But of course, can you imagine how it's difficult to obtain this result, and how it's difficult for a patient to recovery after surgery like this? Why? Because we have to consider the complication of this aggressive surgery. If you see the complication of free column osteotomy, like the case I show you, are very high, and roughly, you see here, are roughly 90% between major, minor, and requiring a revision in this paper of Larry Lenke, 20%. So you have to think about this. How you perform the pedicle subtraction osteotomy? Just an example. I show you why it's so aggressive. We have to expose all the, in this case, it's a lumbar spine. You see here, we have to remove all the posterior joints, like here. We have to go inside the pedicles. We have to cut the lateral wall of the cortex of the body of the lumbar area. And then we have to retain the dural sac, the cauda, and the roots. You see here very clearly. And then we have to crush, to interrupt the posterior wall of a lumbar posterior. The PLL must be cut, and also the cortical wall. And then here, you see here, an example, you close the osteotomy, and you see here how the 2 screws before and after the closure of osteotomy have a clinking of the cauda. So it's very important to do a very good decompression of the roots, otherwise you can have a damage of that. Of course, this must be done with a neuromonitoring. It's mandatory to have it, and this is just an example. Another kind of osteotomy is the coronary osteotomy. This was very well described by the Italians, my friends Pedro Bergiano, Claudio Lamartina in his group, and is a modified pedicle subtraction where you can cut the angle here, you see here, and you close it, and you can reach more than the normal. Usually with a PSO, you can reach between 25 and 35 degrees. You see here, the green lines are the coronary osteotomy. In this case, with a normal osteotomy PSO, you can reach 25, 26, and with a corner osteotomy, you can reach 41. And maybe if you do it caudally, you can also achieve roughly 60 degrees from one level. So it's very aggressive. An example of what I'm saying, this is a patient that, of course, has a severe unbalance, sagittal unbalance. This is a patient where I have operated some times ago. You see here, typically the compensatory mechanism when now is the extension of the hips and reflection of the knees. Look at here. He tries to compensate with this situation, but of course is very not well accepted for a long distance. He can work in this way for 2 minutes. Otherwise, the strength of muscles is very low. So we have assessed these patients for an aggressive surgery because he was in a good health way, and you can see here this is the CT scan of a whole spine, and you can see that when the patient is lying in supine position, there is some correction. So we have done a corner osteotomy, and this is the correction of the patients after surgery with very well recovery of balance in a coronal and sagittal way. And if you look, the clinical shape after surgery is quite good and is very satisfied of this. But of course, this is a very, very aggressive before and after, you see here. So which kind of question rise now? How I do the surgery of SD? Now I have shown you very aggressive it. So of course we have to use the proper classification. As I showed you before, we have to study very carefully the patients. We have to assess the coronal and sagittal balance. We have to select the proper area of fusion and instrumentation. And you have to study the risk stratification for this kind of surgery. And this is very, very important point. You have to recognize which are the limits of the surgeon's experience, means how many cases has done, and the hospital teams. You need a very good anesthesiological team, a very good ICU, a very good cardiologist, because adults, the complication for this kind of patient is higher. Comparing to adolescents is nothing to say. That's why I say the experience must always drive a surgical best solution for the patients. There are some papers of this, what I'm talking to you, the risk stratification. This is was a paper of 2019 that talks about the development and validation of risk stratification models for adult spinal deformity surgery. And if you look at the table 3 of these papers, which are the most important of these predictors? This is the rank starting from 1 to 15. And you see the importance before and after. This is for the complication. You see, the complication are after the blood loss, the last instrumental vertebra, the age, the surgical time, the SVA, the OD walking, T1 sagittal tilt, OD sexual life, lordosis gap, and so on. And also the readmission to the hospital are different. The variable in this list are important. The pelvic tilt, SRS-22, LIV, and so on. So you can find this in these papers a lot of good indications. Another papers I like is this: surgeon risk perception in ASD surgery, the value of objective risk assessment on decision making and patient counseling. And this is very interesting because in a group of a lot of surgeons, experienced surgeons, I was in this study. The conclusion on this was that this study, but also expert surgeon, ASD risk perception is heterogeneous and highly discordant. Available validated MLNSD risk calculators must done. So there is no a great consensus in this. That's why it's very important to have a very great experience. Let me show you some other cases. This is a woman that has a low SF36, so she's very suffering in global health care. ODI is very high, SRS22 is very low, so quality of life of these women is very low. The assessment of the sagittal and coronal is this one. You can see here the numbers. We usually assess the patients with a software where we can think what to do. This is the clinical shape of a patient, completely unbalanced in the coronal and in sagittal way. And this is what I'm saying. We can do a prevision of surgery, and you see here we have a thing to perform a PSO in L3. So you have rebalance in the spine. This is before surgery, of course, and then we go to surgery. We go to surgery, and this is what we have done. See here, before and after. Before and after lateral view. A long instrument, of course, needs a long lever arm to have a good reconstruction, a good recovery, a good correction of this case. But finally, you have a very good clinical result. You see here, normal shape of the lumbar and thoracic area you see before, and even if in lateral, in coronal has a little bit out of compensation, it's not a big issue, because usually when the decompensation is less than 4 centimeters, like in these patients, there are no problems of pain. But we don't have always to think of aggressive surgery. Why? Because ideally, every deformity correction should be performed with a minimally invasive way. Why? Of course, these are a list of whys, because we reduce the rate of bowel infection, we reduce the tissue damage, we reduce the blood loss, we reduce the length of hospital stay, we reduce the use of analgesics, and we reduce the cosmetic scare. So there is a lot of publication regarding this. Let me show you what I mean. This is a woman of 71 years old. She has a mild scoliosis with 35 degrees in the lumbar area. She has a good sagittal alignment, but she is full of pain, and ODI is 55%. Vas leg is lumbar is 9, and vas leg is 9. So it's very high. She suffers, but we can do a minimal invasive surgery for this patient. In which way we can do? This is the clinical shape of a patient, completely different of a patient that I showed you before. So we can think to MIS. In which way? Giving her an anterior support that can be done in lateral, lumbar lateral interbody fusion, in oblique, in alif, or in cliff. I am very expert in lateral, and I started my experience many years ago. And I plan to do this surgery first anteriorly and then posteriorly with MIS. This is during surgery. You see, this is a step by step what I mean in a MIS lateral approach. This is the retractor. This is during surgery. You see here, we put the retractor in the body, and then we key wire in the disc. You see here, the spine is completely straight now because it's in a lateral view. You see, if this is a retractor, we put this is the blades. We cut all the disc, and then this is a trial, and then we step by step insert here the cage, and this is the peak cage. This is an old cage, but I show you why it's interesting, because we have done only X-leaf, and this is the result after surgery, and she was planned to do the posterior approach after 2 weeks, but she refused because she was so fine And she refused to do this. And look at here, after 1 year, she was perfectly fused and she was completely recovery for the activities. And this is the scores are very, very good. But why? Because the balance was very satisfying in the coronal and sagittal. That's why she fused very, very soon. In this case, is completely different of the previous one. Even if the coronal is quite the same, you can see here there is a lateral listhesis that means that it is very unstable situation. And you see here the lumbar area, the lumbar lordosis is very low. So in this case, this is the bending films. We have to think to do a more aggressive surgery. This is the surgery during the lateral approach. Again, it's very interesting. In this case, we have used the titanium cages. You see here, step by step. And now, in the same surgery, we have rolled the patients, and then we have done the posterior approach with a percutaneous screws. This is the view of the surgery during the posterior approach. So usually I insert previously the key wire in the pericles, and then step by step I insert the screws, and this is the result of surgery. You see here the recovery, good correction of in coronal and especially in lateral, and the patient was satisfied. This is a before and after surgery. You see here the recovery of a lumbar lordosis, and this is 1 year after surgery. Again, an example. This is a patient of 81 years old, and if you see here, is very aged spine, but is in a good situation, health situation, and but he has this course, very, very bad. So you can do a lot of surgery in a patient like this, but you see here, you can think to do a restoration of the sagittal balance. In which way? Instead of using an aggressive pedicle subtraction osteotomy, we can do a different surgery. We can do a lateral approach, and we can do an anterior caudal realignment using the so-called 30 degrees lordotic cage. And of course, you have to release the ALL, otherwise you can't reach a good correction of the lumbar area. I show you what I mean. This is the clinical shape of the patients during surgery. Let me see how to do. Okay. You see here, this is the retractor, the pain field. This is the ALL that was cut, and this is the disc space where we will put the cage, the lordotic cage. Okay, and this is step by step of what I mean. This is here again the retractor, the pain field, the disc space. We are working in the disc space to release all the disc. And you see here, we insert the cage. In this case, this is a PIC cage, and we fixed it because otherwise this cage can float anteriorly because the ALL is cut. And you see here, step by step, we increase step by step the lumbar lordosis of the patients. In this case, we have put 3 lordotic cage, 1 in 5-1 posteriorly, and you see here, and 2 laterally. And look at the final result. Is a step by step again. Step by step. This is the posterior one, and this is the result after surgery. You see here, 2 lordotic lateral cages and 1 lordotic posterior And this is a final result. Usually I use a double rod. I explain you why, because we increase the rate of fusion with a double construct. The rate of rupture of the devices with a double rods construct is 4 times less. You see here the alignment of the spine, and finally a good result. So we don't have any blood loss. We don't have any great complication to do in a patient in over 81 years old. There are some publications of this that I told you. There is a book of MIS spinal deformity surgery that was published very recently by Michael Wang, Liu, and Praveen Munameni and Greg Anderson, and they have published an algorithm of MIS minimal invasive evaluation treatment for adult degenerative deformity. And I show you this algorithm. So the assessment of a patient is very, very important. You see here, we start from the neurogenic claudication, so radiculopathy, and we have to assess if present or not. You see here, this is very important. So if not present, we can go in this way. So SVA is normal, and if we have anterior osteophyte and less than 2 millimeters of subluxation, we can perform only MIS decompression sometimes. We have to think only to neurogenic problem. Or the second category, number 2, we can do MIS decompression and fixation only over the segments we have decompressed. If we have back pain, we go here, and we have an holisthesis more than 6 millimeters and coronal cob more than 30 degrees. If we don't have this, and we have only collapse, we can think to again to the category number 2, and we can perform only MIS decompression and fixation of the compressed segments, or we skip to number 3. We can do an MIS decompression and fixation of the apex of the lumbar curve. Let's go to another situation. Lumbar kyphosis, as I show you in some cases, is not present. We stay in MIS led number 3. But if it's present, we have to do something more aggressive. So maybe MIS anterior and lateral approach, as I showed you before. So we have an indirect or direct foraminal decompression, MIS posterior spinal fusion to include cob angles of the main curve. And then we go to global imbalance more than 5 centimeters. And this is very interesting. If the deformity is very stiff and we have a thoracic hyperkyphosis, we have to stay here in number 5, open surgery. You see open surgery with fusion to thoracic spine plus or more or less osteotomies, or the last category number 6, open surgery with osteotomies. But it's very similar to the scheme that Lenke has presented some years ago. So I go. This is finally the Olberit. What is news for us? Probably the future should be to use the intelligence, the artificial intelligence, because spine care model, we have to increase the quality of our surgery using AI, because this is a new era of research and clinical decision making. As I just show you, there is no consensus in many experienced surgeons. So that's why the artificial intelligence is very, very important in our future. So I'm going to the conclusion, then we can discuss what I have to say. So when operated adult deformity, it's very simple. Always when it's necessary. I'm joking about this, of course, but the assessment is very important, because before we have to do a very, very, very valid global assessment. We have to think of a risk stratification. It's very important to have a very good experienced team. That means not only the surgeons, but all the aware, all the tools, all the devices, all the anesthesiologist team, the cardiologists, and so on. And we have to answer to the patients, because sometimes the expectation of the patients are very high and you can't afford this for them. How we can do this? We can do in hybrid, we can do in open, we can do in MIS. It depends on what is your experience, how many cases you have done. And why? Why is very important. Why? Because when you do surgery for these patients, you really modify the quality of life. Why? Because deformities in adult age are very painful, and surgery can really ameliorate the quality of life in these patients. I have many patients on my waiting list. Of course, the assessment of the patients, my team knows is very important. We don't operate every patient. We operate the patients that can have a benefit of a surgery and reduction of a complication that can raise from our surgery. More surgery you have done, less complication, of course, you can assist. So I think this was the last slide. This is my hospital, so in Verona. So thank you for your attention, and of course, for any members that want to visit my unit is very welcome, and it's important only to I have a lot of members of not EANS, also spine surgeon, neurosurgeons that are coming to visit my clinic, and I open for fellowships in any moment. So thank you again for your attention. Okay, Florian.
Thank you very much. Excellent comprehensive presentation on all aspects of adult deformity correction. So to all the participants who are online, you can ask a question via the Q&A box or the chat. I will check both options. So please type in your questions, and I'm going to give those questions to Massimo. So there's already one question, which is probably one of the hard questions and the often asked question: which levels have to be involved into the instrumentation? And now I would like to add on, you had some images, you had those impressive cases, and you had some images where you stopped at L1. There was this old rule, you should never stop at L1, then you go to T10. I from time to time stop at L1 as well. And how do you select your upper level, and how do you select your lower level? When do you stop at L5? When do you go to the sacrum, and when would you go to the ilium for the instrumentations?
Okay, thank you for the question. It's very interesting. So starting for the lower instrumented vertebra, the assessment of SVA, pelvic tilt, pelvic incidence is very important. Sometimes it's very difficult to obtain a good realignment if you don't put on your instrumentation also the L5S1. In some cases, in the younger patients where the disc is very high and the assessment of the X-rays and CT scan can permit you to avoid to fuse a 5-1, I think it's a good option. But usually when you have a severe SVA, it's very difficult to don't include 5-1 for a good realignment of the spine. But depends of the symptoms, depends on the quality of the disc, of the joints, of the L5S1. Of course, you increase the problems if you fuse to 5S1. Always I put also in the long construct, I put the S2AI screws with hydroxyapatite of cement. Sometimes it depends on the quality of the bone. And of course, I know that in the future of these patients, he can have a problem of SI joints. It's another problem, we can't fuse not affected segments. We think to fuse only if they are painful. So I don't fuse now. There is a trend to fuse also as I joined after long instrumentation to avoid, pseudoarthrosis. It's a big issue. It's very difficult to say this. It depends patient by patient. Regarding the upper instrumentation, I know L1 is sometimes a critical. It depends how is the sagittal alignment of the spine. I mean, if you have a thoracolumbar junction that has the more than 20 degrees, of course, I prefer to go over. Maybe I stop in T10. Of course, you increase morbidity when you go to T10 because it's a long instrumentation. Maybe it's a problem of anesthesiologist with a problem of blood loss. So it's a challenge to stop in L1, but it depends on the quality of a bone you have and the sagittal alignment that you have to assess before. And where to stop in the upper part, in the thoracic, it depends how is the global assessment of a spine. Of course, always you never have to stop at the apex of a thoracic area, so never stop in T7. Maybe it's better to stop in T2, T3. Of course, you have to avoid the problem of proximal junctional kyphosis, but sometimes it's impossible to avoid. So there are so many issues to discuss for every patient. That's why the counseling to the patient is very, very important. And you have to notice to him that the complications are high, but usually they accept the complication. But the quality of life is very low, and they don't have another opportunity to stay better. So they accept the eventual complication that can happen. I think it's the age of our patients are increasing because the expectation of age are in our society are higher, and you can stay active. You can see people playing golf at 80, 85 years. You see, it's fantastic. It's nice, but they can play only if they are fine, if they are in good health. So,
okay.
Yeah.
So you already mentioned quality of bone, that this is a one factor which is important for the decision on how long your
very important
needs to be. What do you assess every patient prior to surgery for bone density? We do. And what would you do if you have a patient who you need to operate because he's very symptomatic from his deformity and has a poor bone quality? Do you pre-treat those patients with operative treatment and then delay surgery, or what's your strategy for those patients?
If you have a quality of Hausenfield assessment or the DEXA is very low, we put on treatment maybe with teriparatide for at least 6 months. Even if it is off label, but they do it. In Italy, teriparatide is only used for fracture of more than 3 levels. So in this case, of course, when you do a big instrumentation, you have to increase quality of bone with the teriparatide. And after after 6 months, we operate him.
Okay.
Not less.
So you delayed surgery.
Yeah, we delay. Why we delay? Because the complication rate is higher, So for sure, the patient has more than 50% of rate of complication, and failure of instrumentation is very high.
Yeah. Okay, as you mentioned, instrumentation failure. There's another question concerning PJK, of course. So what are you? There are several description of strategies how to prevent PJK.
I see the
correction. Do you use bandings as a landing zone? How do you have any special strategies for how you angulate the pedicle screws, and what are your strategies to prevent?
Visible, I show you this the pen. The orientation of a screw in the pedicle must be from up to down and you have to cover the kyphosis. And very important thing is not to damage the ligaments and the joints of the upper part. But you don't stay very aggressive. That's my best suggestion to surgeons, to avoid to be aggressive. If you can use screws, we can use the bends, we can use the hooks, but if you are very aggressive, PJ cake happens. It depends on the experience of surgery. And usually, if you do this and the orientation of the screws is good, and if the quality of bone is low, put cement inside it, and probably you can avoid. Probably it's not, sometimes PJK is normal, is not painful. Sometimes it's painful, and you have to come back to surgery to correct it. But when you have a PJK less than 10 degrees is acceptable for the patients. They don't need further surgeries. What do you think about? Are you the same?
I use those, as you said. I think it's important to have those screws going down, not being horizontal screws close to the end, but going
the orientation
down
must be.
I don't use any tethering.
But there is not any advice, because there is no one better 100% of the other. So it's important to do this.
So what, and some comments about double rods? Why double rods, and where double rods? For the area where you do your osteotomy, or for the whole construct? Why do you use double rods?
I use
in which area?
From roughly 6 years, I'm using double rods because the rate of failure decrease of 4 times. So especially when you do the PSO, you reduce 4 times the rupture. But remember that sometimes, even if you have 4 rods, you can assist to a failure. So it depends how you put the patients on the sagittal and coronal balance after surgery. You can have 4 rods, but if the patient is unbalanced, for sure, in a couple of years, he will come back with a failure of implants, for sure. There is another question here. Why during instrumentation you sometimes keep some levels? It depends. It depends, because you decrease the hours of surgery, you decrease the blood loss. In some areas you can avoid, in other no, but in some areas you can avoid, you can skip. Because the important thing always is to balance the spine. If you balance the spine, the density of implants is important, but not so important. I started my experience when I was very young, and we made fusion without instrumentation, and we put the balance, and we have a very, very successful fusions, even if we use only casts after surgery, because the patients were well balanced. If you have a good instrumentation, a high density, but unbalanced spine, he will fail for sure. He will fail.
Okay. I have a question regarding your surgical planning. You already showed your images that you use a computer system for planning your osteotomies.
Yeah.
What is your advice for the level of osteotomy? How do you plan on which lumbar vertebrae you do a PSO? And what is the extent of correction you plan in the sagittal plane? Do you use any age-adjusted parameters, saying a younger patient needs more correction than an older patient who gets along with less correction, and being on the safer side when we use less correction?
Yeah. I usually try to balance the spine, and if I sometimes I have to do a double PSO. I didn't have time to show you some ankylosing spondylitis where I have performed, but ankylosing spondylitis usually is a surgery that I do not in an older age. If the patients depends on how is the patient's the age, the condition of the patient, the comorbidities. But usually I try to do a PSO in L3 or L4. Distally, more distally you stay, more correction you can achieve to the, but it's more difficult to do a PSO in L5 than to do in L3. So you need more experience, but you can have a very successful achievement and rebalance of the spine. But of course, it's more aggressive and you can have more blood loss. So usually I stay on L3 and L4, and I use the software for doing these measurements and to understand how much correction I needed to correct the spine.
Okay, now we have another question. How do you avoid a non-union in the lumbosacral junction?
Yeah, I use the SI2 joint, SI2 iliar screws, sometimes double, and I put a cage in 5S1, and I balance the spine. But I stress this concept. You can put any kind of instruments, any kind of devices, but if you don't balance the spine, you will fail for sure. So if you will balance the spine, you put the screws in. I use S2 AI configuration because it's better, it's simple compared to the old fashioned. And in this case, I decrease the non-union, but of course I can't skip completely the non-union. Sometimes I have to come back. I have some cases I have done again, and I fuse SI joint with the MIS way again. So it's important.
Okay, and one final question we have in the Q&A box. Is there any cutoff age for usage of magnetic rod? So it's more from the juvenile, idiopathic, adolescent scoliosis.
No, yeah, good question, but not in adult. In adult is not a good indication, of course. I use an early onset scoliosis very often. And also I use now in severe deformity of adolescents, of a young adult, where maybe you have a deformity of 100 degrees, and instead of use a halo traction, you can use a magnetic rod, and every day I do a distraction of 1 or 2 millimeters, and then I go back to surgery after 2 weeks, and the spine is less stiff, and you can achieve a good correction.
Good. This was our last question we had. Massimo, thank you for this excellent presentation, very comprehensive overview. Thank you for the discussion. I think this was very, very educating about adult deformity. It was a pleasure to have you here. So we will have our next spine section webinar in beginning of October. I don't have, unfortunately, I don't have the exact date, not with me, but it will be announced in a timely fashion. So that's it for today. Good evening to everybody. Massimo, thanks again.
Thank you, Florian. See you very soon. I hope on presence. Yes, I think in Edinburgh, we will see there.
Edinburgh, definitely. November, yeah. Advanced course, EANS.
I will be there. I will be there. And thank you so much. And have a nice day. And thank you for all of the audience that has assisted to my presentation. Thank you so much again. Bye-bye.
Thank you. Bye-bye. Good evening.
Bye-bye. Bye-bye.